Top Bed Talk. So I'd like to introduce our final speaker for this session, who is Dr. Esteban Salas Rezola from Alicante in Spain, whose name I've been butchering all morning.
Yeah.
Specialist in anesthesia and critical care.
Yeah, true.
And well, you're going to tell us about the NOL Index for opioid sparing analgesia strategies guided by that.
Thank you so much. Thank you to the POM also to the opportunity to be here. First to say, I'm not here to sell nothing. Everyone here has a lot of experience, so I'm just telling you mine. So the title is Opioid Sparing Analgesia Strategies Guided by NOL Index. And this is my operating room, so I can have not more monitors. But look at this. We have the Bs with the DCA. We have hemodynamic monitors. We can see cardiac output. We can see systolic volume, variability of the systolic volume. We got also CO2, and we got ventilation monitoring. And what happened with nociception? Come on, we are in 2024, and we are going to the moon again, and there's nobody telling us what to do with opioids intraoperative. So the challenge is the assessment of the intraoperative nociception. So I make you a couple of questions. Some of you yesterday in the workshops give me a good answers. So which parameters do you use to evaluate this nociception and guide your strategies? Because we said, okay, that for a good in the eras and to a good enhanced recovery after surgery, we must, save some opioids, whatever. So which strategies and what do you look at? Do you look at arterial pressure, heart frequency, both? So we got hypnosis, we got relaxation, and we got nothing here. And I tell you something that you don't measure doesn't exist. It's not my phrase, it's some physics in the early 20s. And we know this. We know the complications about the excessive and insufficient opioid use. We got overdose, hypotension, opioid hyperalgesia, respiratory depression, nausea and vomiting. I hate nausea and vomiting. I performed for 10 years maybe obese patients, all the bariatric surgery. So for me, it's disgusting. Okay, it's always disgusting, but with a gastric bypass. And the underdose also makes his own effects. Tachycardia events, chronic postoperative pain, and both leads in a delay of postoperatory recovery. We are talking about this in head cell recovery, okay, these ERAS guides. And there's a huge variability needs of monitoring. There's some people that this is the plasma, alfentanil concentration, and the percent of probability of no response. There's some people that with 100% nanograms milliliter of alfentanil plasma reaches this no response, and there are others that need 500 nanograms. So there's a huge variability. There's individualized. Let's monitor each one. We cannot give everyone for appendicitis 200 micrograms of fentanyl. Why? We are all different. Well, this is the PMD 200. I've been searching for a good monitor since I was a trainee because some professor told me, Esteban, put some more fentanyl. And I said, why? And he told me, oh, it's time for fentanyl. I didn't understand that, so it's time to dance or something like that. I don't know. So I tried the pupillometry, I tried the ANI, I tried the QNOX. All of them is one parameter monitors. So this is very simple. It's like a sticker, okay? It's based in artificial intelligence technology. There's like 2,000 clinicians inside this monitor taking decisions for you, and you just have to look one number. The algorithm is called use the random forest. So there's a lot of variables and they are choosing the best way. We can show his beta. It gives us a photoplethysmography that not only measures head rate, but also variability and amplitude of the wave. And also, it has a galvanic response of the skin, because with a nociceptive stimuli, the skin gets a little bit with sweat, with a little bit more fat. So it changes the galvanic response. We got also two more values, temperature and accelerometer, to test movement, okay, in order to not make errors, okay, of measuring. So we got four values: heart rate, amplitude, variability, and galvanic response. With these four values, we approach to a nociceptive stimuli, okay? Because only the heart rate, come on, a tachycardia comes from other things. Hypovolemia, tachycardia, for example. This is how you will see the photoplethysmograph wave, the condom tags, and the number. This is the trend of the NOL. So I'm going to show you some cases, and to understand them, it's just the way it appears. When you have a number above 25, it tells you that you have a high nociceptive response. Between 10 and 25, you got adequate analgesia, and below 10, you are overdosing. Or just in case you have a nerve block, peripheral or epidural nerve block, it will go down this index till 0, 1, 2, okay? So don't be afraid, your block is working. And these combinations of these four values is really superior to other parameters methods. So you can hear the raw analysis with the sensitivity and the specificity. So this is the only when you measure the heart rate and the arterial pressure and the NOL index, the four parameters together, okay? And also we have thousands of papers, not only this one, that shows that with remifentanil anesthesia regimen, we have a 30% less remifentanil consumption when you use this index, when you monitor, when you measure, okay? And you have no significant differences in morphine consumption, maximum pain, pain upon arrival to PACUs, pain after 30 minutes, pain after 60 minutes. So to start talking about sparing strategies, we can resume in two: regional anesthesia, multimodal anesthesia, okay? So I bring you some opioid-free anesthesia. I performing for 10 years opioid-free anesthesia. So I believe that there's no opioid-free anesthesia. So I like to talk about less opioid-free now. So some cases to understand what I do or what's my experience. This is a laparoscopic gastric bypass. I'm going to use a cocktail, Dr. Mueller cocktail. It has dexmedetomidine, ketamine, lidocaine, and magnesium. So let's see what happened. This is the starting time. When the patient is awake, we have always a very high NOL index. This is intubation. I start the mulimix, that's what I call the cocktail, with all these drugs. They came down below 25. I wait a little bit, came down, still down. I add some ketamine, a bolus extra of ketamine. Stay down. And I had here a high blood pressure event. So before having this monitor, maybe with this blood pressure, I will add something else. And don't you, some fentanyl or whatever. But I had a very low NOL index. So I put some rapidil, not more analgesia, vasodilators. So I treat hemodynamic events. I don't treat hemodynamic events with analgesia. So it stays very, very, very low, the index. And here, rise up a little bit the index. So it rise a little bit the cocktail. And it came down again, really low. This is the Fouché to test the anastomosis. Very low, really low. And this is the end with the awake patient that always goes up again, okay? This is the old session. a NOL below 25 in a 91.9% of the session. And yes, we have some papers, and this is from this year, that tell us that we can guide our opioid-free anesthesia, because when I began with an opioid-free anesthesia, I thought, oh, come on, I'm going to kill the patient or something like that. I don't know what I'm doing without fentanyl or... Well, you can guide the opioid-free anesthesia with this monitor. And let's talk about regional anesthesia, sparing opioids, okay? So this is a massive eventration. What I did is a QL1. It's a block of the quadratus lumbarum. It's like a tap block, a little bit posterior. You have here the external oblique, the internal one, the transversus, all of them ends in a ligament, and under that, the quadratus lumbarus. So, well, this is a horrible echographic picture, but it's here, the local anesthetic. So what happened? This is the surgery. This is the block with ropivacaine. So one question, how do you trust in your blocks? You perform an interscalenic and axillar and starts the surgery, and I don't feel very comfortable sometimes, don't you? So this is the way to trust in your blocks. Look at the abdominal block. Look at this. Raise it up a little bit. I add some fentanyl. Little bit. Went down and down. Really down. And the extubation. The total session was this. She's pregnant. She has appendicitis. Please give me an epidural. And don't use opioids. Maybe a little bit, but because we are in the fourth week, fourth week, we can a little bit, but I really want to trust in that epidural. This woman was really afraid what was going to happen with the little kid inside her. So this is the intubation. She had this from the beginning, 95 heart rate, 95. So this is the epidural. The first bolus, I used just bolus through the epidural, really went down to 0. Okay? 95 of heart rate, and she woke up. And she was perfect, smiley, happiness, the total of the surgery. This is how it looks like when you put a bolus through the epidural in your monitor. And some conclusions. So the strategy is easy, or strategies. Just customized opioid dosing. Less hypotensive events, lower opioid consumption, less side effects. You can confirm the efficacy of the regional anesthesia, epidural, peripheral blocks. And you can confirm also your multimodal analgesia. Need less or supplemental analgesia. And thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.